open as it starts coming out. The two semilunar valves, remember, are the aortic valve on the left side and the pulmonary valve on the right side. But they've got to be open for that blood to come shooting out of the ventricles. Blood starts to flow out through the pulmonary and the aortic trunks, as we just mentioned, and that accounts for what we call stroke volume. So the stroke volume is the difference between the fullest full of the heart, when the heart's full of blood, when the ventricles are full of blood, that's called end diastolic volume, remember. And now that it's completely emptied, as far as it's going to empty, we call that end systolic volume. It's not listed here. But the difference between fullest full and emptiest empty is the stroke volume. In other words, that's the amount of blood that got pumped by that one heartbeat. That's what stroke volume is. For each stroke, that's the volume of blood we squirt out. Now, do we completely empty the heart? No, we don't. It squeezes down, it pushes a bunch of blood out, but there's still blood left in the heart, as we'll see here. So, look at these numbers down here. Here is the beginning. This is end diastolic volume. This is the fullest full. It starts to squeeze. Blood starts to flow out and gets down here to end systolic volume. And it kind of stays there, and then blood starts pouring back into the heart to fill it up again. So the difference between end diastolic volume, fullest full, and end systolic volume, emptiest empty, is what we call the stroke volume. Now, to put real numbers to that, you notice here that fullest full is about 130 cc's, and emptiest empty is about 50. Okay? So you've pumped out, what's that, 80 cc's? You pumped out 80 cc's, that's your stroke volume, but you've still got 50 left. Okay? My grandmother had a cardiac evaluation one time, and it found that her ejection fraction, the percentage of her heart that was ejecting, was 15%. In other words, if this was 100, she was only ejecting 15% of it. Her heart, instead of going like this, was going like this. And her stroke volume was extremely low. It was about 40 cc's or less per beat. She didn't live too much longer after that, actually a couple months. But those are just numbers to keep in mind. So once the heart is finished squeezing, and then it squeezed all it can squeeze, it's now to the emptiest empty, and now the pressure that's in that ventricle starts to fall, and as the pressure in the ventricle starts to fall, then it squirted all that blood out the aorta. That blood kind of can't go any farther because there's no more pushing, and boom, it comes back. And when that happens, the semilunar valves snap shut. Lub. That's a heart sound. Okay, when those valves are snapping shut, that's what you're hearing. The ventricles at that point still contain that end systolic volume, the ESV, which is about 40% of the end diastolic volume. In other words, we eject normally, normal ejection is about 60%. It can get a lot less than that. All right, so now it's time for the ventricle. It's just squeezed, it's just emptied, and now it's time for it to relax. And that's called ventricular diastole, obviously. The ventricle is going to relax. But even when it's relaxed, the pressure in the ventricle is higher than the atrial pressure. Atrials are always very low in pressure. Right at the end of at the beginning of ventricular diastole, all of the heart valves are closed for a few milliseconds there, and then as the ventricles start to relax, it's the same thing as it was on the way out. There's pressure in the heart. The ventricles have already contracted and completely pushed it out as much as it's gonna, and now the ventricle starts to relax. But before it relaxes too much, as it starts to relax, it drops the pressure. Pressure starts to drop, but yet the heart hasn't started to refill. So in other words, it's called isovolumetric. The volume isn't changing because there's no blood going in or out. It's just relaxing. And that's over here in this part of the, really right in through here, I guess. This is isovolumetric relaxation. Here's the end of systole. This is the end of the contraction coming down here. And then this part is isovolumetric relaxation. Number 7 coming down here, about along in there. Okay, but you can see that the volume isn't changing anymore, but the pressure is changing. The pressure is coming down. Have I got you confused yet? You got all this down? Okay. So we're almost to the end, and now blood has been pouring into the atriums while this ventricle has been doing its thing. The atrial pressure now is higher than the ventricular pressure, and once the atrial pressure gets higher than the ventricular pressure, then the AV valves open again, mitral and tricuspid open, and that allows blood to start pouring down from the atriums into the ventricles again. The AV valves are open, the atriums have been passively filling with blood just coming back from the vena cava and so forth. And now, and then it just kind of pours on down into the ventricle, and it's just, that's where we started the cardiac cycle, is when the atrium then gets ready to contract to start off another cycle, is at this point right here. Okay, so one more time, same diagram. The things that I think you need to learn where the heart sounds are, and I will tell you that the heart sounds involve closing of valves, okay? That it's the snapping shut that makes the noise. So this is when the left AV valve closes. That's lub, that's your first heart sound. And here's where your aortic valve closes, and that's dub, that's your second heart sound. So if you're listening to your heart, what you're going to probably hear is lub dub, lub dub, lub dub, lub dub. So the lub is right here, the dub is right there, and notice that the period of time between the two heart sounds is a lot less than this plus that, the times between the second one coming back to the first one. So it's lub dub, lub dub, lub dub. I'm exaggerating it. But the point is there's more time during diastole. The time during systole is the time between the two heart sounds. Heart sounds, number 1, S1, is produced by the AV valves. It's a very loud sound. You won't have troubles hearing it. S2 is also a loud sound caused by closing of the semilunar valves, the aortic and tricuspid, aortic and pulmonary valve, excuse me. We have 2 extra sounds. These are very abnormal. You should never hear an S3 and S4. Usually they tend to indicate heart failure. Somebody's going into heart failure. And the way I used to always remember them is Kentucky, Kentucky, Kentucky. If you're hearing 3 sounds instead of just lub dub, lub dub, lub dub, it either sounds like Kentucky, 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 or it sounds like Tennessee, Tennessee, Tennessee. It's just a matter of emphasis on where's the loudest sound. So Kentucky, Kentucky, Kentucky is S3, and Kentucky is right above Tennessee, right, on the map. I used to live back there, so I know. S4 is the lower one, so it's Tennessee, Tennessee, Tennessee. But don't worry about that. I'm just telling you that for your own interest. Someday you'll be listening to hearts and you'll hear that. And you'll say, oh, I remember when session said it. Yeah, it does sound like Tennessee, Tennessee, Tennessee. All right. What's a heart murmur? A heart murmur is anything that causes abnormal sounds. The 2 main sounds are what we call a heart murmur due to stenosis. In other words, the valve doesn't open up all the way. It only opens up part way, usually due to scarring. And so the blood has to squirt through there, and you can hear it go ch, 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 with each heartbeat, it's going through there, through this narrowed valve. And obviously that's a thing that occurs during systole, right? Especially if it's an aortic valve. All right, and then the other one is called regurgitation or insufficiency. So mitral insufficiency, for example, means the heart pumps through the mitral valve, and then when the ventricle contracts, the valve doesn't close itself all the way, and it allows the blood to regurgitate, come back up. So it goes, but it's a diastolic sound, right? So keep those in mind. Here's just the same diagram we were just looking at. Here's the heart sounds, S1 and S2. Like I said, don't really worry about S3 and S4 because they are abnormals. On the valve, this graft up here that I was telling you about, this is the point. The ventricle starts to contract. It does this isovolumetric contraction. It gets to this point here, and it pushes the aortic valve open, and blood starts flowing out of the heart right here at this point. It squirts it all out. Blood goes up into the aorta, and then it's done squirting, and it comes back a little bit due to the elastic recoil of the aorta, and then those valves close, and this is the really loud S2. Same thing happened down here. These are with the AV valves, and the AV valves, of course, are the mitral and the tricuspid. Remember that first day when I drew that diagram up here and I said, you just got to understand this? All of this talk doesn't make any sense if you don't understand the order and where the valves are and the ventricles and so forth. This little diagram over here goes a lot farther than this is how I learned it because we didn't have all the fancy machines. We didn't have any cardiac ultrasound at all in the 70s. Now they can put an ultrasound probe on here and they can read every one of these numbers, every pressure, every flow. They can calculate the volume of the ventricle when it's full. They can calculate the volume of the ventricle when it's empty, just off of sound waves and gooey stuff on your chest. But we used to always have to really try to figure out where these murmurs were coming from. And usually aortic valve murmurs come from this yellow area right here. Pulmonary valve murmurs come from up here. Think about the way the pulmonary valve is pointing. It's pointing up that direction, kind of coming out of the right ventricle. This is the aortic valve. Remember when the heart is here, the aortic valve is located about there. So if noises were coming from the aortic valve, you would hear them up here. This is usually the mitral valve area is down here at the apex of the heart, and the pulmonary valve sounds would be heard in this area right here. Please do not memorize those things. I guess if there's any that you might want to learn, it would be the aortic right here, and the mitral, which is over here, left AV valve. Usually things on the left side of the heart make more noise than on the right side of the heart because they're much higher pressure and the squirt is a lot harder. Okay, so we've kind of talked about these, but let me just go over them with you again here. There's some, because we're going to be talking about functions of the heart, how well it's actually pumping. These are the numbers, these are the things you need to know very well. In diastolic volume, at the end of diastole, the heart has filled up as full as it's going to fill, and that's called the fullest full, or the EDV. In systolic volume, the heart has squeezed. It's at the end of that. This is the emptiest empty. Okay? The difference between those two, the EDV minus the ESV, the difference between fullest full and emptiest empty is the stroke volume. In other words, how many cc's per stroke are you generating? You can also mention that as the ejection fraction. In other words, what percentage of the diastolic volume is represented by the stroke volume? In other words, what percent of the heart emptied with each heartbeat? Okay? Normal should be about 60%. As I told you with Grandma, it was 10%. very little of the blood was being ejected each time. Cardiac output is really what it's all about. How much blood can your heart pump in a minute? Okay? And the way you do that, and the way you calculate cardiac output, is you figure out what stroke volume is. Say it's 80 cc's, difference between EEV and ESV, and then you multiply that by the heart rate. So if the heart is beating 70 times a minute, and it's shooting out 70 cc's with each heartbeat, you can calculate calculate cardiac output quite easily. So cardiac output is really what it's all about, and that's when a patient is having troubles or sick in any way. One of the numbers you really like to have is, well, what is their cardiac output, and then what can we do to improve their cardiac output? Because the more blood their heart pumps, the better they're going to get. It's going to improve their renal function, it's going to improve their lung function, it's going to improve their liver function. All of your organs depend on a good supply of blood, and a good supply of the blood depends on your cardiac output. It says it's a simple model to measure stroke volume. Well, that's true. If you want to think of your heart as a bicycle pump, there you got it. I'll just leave it to you. If that's simpler, more power to you. Okay. Cardiac output, as I said, heart rate times stroke volume, milliliters per minute. I think all of those numbers should make sense to you. You should understand all of those. You will be asked to solve some little problems to calculate, well, what is cardiac output if your stroke volume is X and your heart rate is Y? And what is your stroke volume if your end-diastolic volume is X and your end-systolic volume is Y? You know, that sort of thing. So, how do we change cardiac output? Because that's really what taking care of sick people is all about, making their cardiac output better. Well, cardiac output changes all the time as your heart rate goes up and your stroke, let's just say if your heart rate went up and your stroke volume stayed the same, your cardiac output would clearly go up, right? But you got to remember that when your heart rate goes up, you have less time with each heartbeat for your heart to fill. And if you have less time for it to fill, then oftentimes, even though it's going faster, the stroke volume drops. It's not pumping as much per stroke. So some people do a lot better with a slower heart rate than they do with a really fast heart rate. But that's just those are the things you got to think about from these numbers here. We can adjust people's heart rate really easy. We can give them epinephrine. That'll run their heart rate up really fast. Will it change their stroke volume? Nah, probably not. So so we can change heart rate. We'd like to think we can change stroke volume because we always want to be able to change cardiac output for the better. Remember that the heart has both sympathetic, remember the sympathetic chain ganglions running along the spinal cord in your back, in your thoracolumbar area between T1 and it's about L4, isn't it? Anyway, so you've got these sympathetic fibers that make the heart beat stronger, they make it beat faster, raise your blood pressure, and then you've got these parasympathetic fibers that come from your brain up there, and they come down through the vagus nerve, remember, and they cause your heart to relax, they cause it to beat slower, and so forth. Okay, this goes into what I was just talking about a little bit. At rest, with our heart beating nice and slow, the this slide is confusing me. Just let me think this a minute. I don't like that. I'm going to skip that. because I don't think you'd understand it. The Frank-Starling principle is the most important concept in improving patients' cardiac output. And basically what it says is that as you increase the end diastolic volume, in other words, as you fill the heart up more, you make it the fuller full, even fuller yet, that will increase your stroke volume, and that will increase your cardiac output. The way to think of that is more in, more out. Okay? So when we talk about the Frank-Starling principle, the primary principle of cardiac output, more in equals more out. Now, how do we deal with that? Well, if somebody has lost a bunch of blood, and their blood pressure is low and their cardiac output is low, what do? We fill them back up again. We give them blood, we give them IV fluids, we fill them up in order to fill up this number right here. Once you fill that number up and they've got more blood to pump against, they're going to pump more. That's the Frank-Starling principle. Okay? There are limits to it. Obviously, you can't stretch the heart too much. If you fill it up, you can overfill it. Sometimes myocardium has a lot of connective tissue, a lot of scarring in it, maybe from previous heart attacks or from previous cardiac disease of one type or another. The heart has this fibrous skeleton that only allows it to be so big. And then the pericardial sac can, if your heart gets big enough, your pericardium may not allow it to get bigger, and that will hurt you because your ventricular expansion will be limited by simply the pericardial sac. In systolic volume, we've talked about that's the emptiest empty. And what are the factors that affect it? What makes it empty more or empty less? Well, clearly, the more you put in to start with, the more blood is in the heart to start with, and the more it stretches during diastole, the more you can empty it. We call that preload. The preload is basically how full is your heart before the heartbeat. Increasing preload is one of the main things that physicians and healthcare workers can change in somebody by giving more IV fluid. Contractility means how hard does your heart squeeze. Your heart can squeeze, or it can squeeze if it's not a very good heart. It might squeeze like that. It's not contracting well. That's what contractility is. So every heart produces a certain amount of force based on how full it is. We know that by increasing the preload, filling the heart up more, it'll work better, but still there's a limit to it because certain hearts just don't contract strongly enough. But we can give medicines that will make it pump stronger. Dopamine, epinephrine, lots of drugs. Digoxin will make it contract harder. Afterload. What is afterload? Well, think about that for a second. I just showed you that graph I just showed you of the ventricular pressure, and it comes up like this, and then it comes down, valve closes, and it goes on down, right? And you noticed out here there was that black line came in this way, and they crossed at this point right here, and then this goes up and comes back down, right? So what is afterload? Well, afterload is your diastolic pressure. Basically, it's the pressure necessary to open this valve right here. Okay, this is where your aortic valve opens. At this point, right there. Now, if your blood pressure, I didn't draw that right. If your pressure is, let's just say it's 120 over 80, okay, your heart had to squeeze as hard as it could until it got up to this level right here, until it got to 80, to where it could actually push that valve open and then actually start pushing blood out, which is really the whole idea, right? To push blood out. Now, if you're hypertensive and you have high blood pressure and you take pills for it or don't take pills for it, and your blood pressure, instead of being 120 over 80, is actually 140 over 100, that means your curve comes something like this, and then it goes up, right? So basically, in this first example, your heart had to squeeze from this point to that point before it started doing anything for you, before it started moving any blood, okay? But if you have high blood pressure, your heart now has to squeeze from here to there before it does any good for you, okay? And it's, you know, that may only be 20 millimeters of mercury, but think about it. It's 20 millimeters of mercury every heartbeat, 24/7, day and night. Your heart is working that much harder just to get the first drop of blood to leave your heart. It has to pump all the way up here to 100 or 110 millimeters of mercury. And that may be all the difference between your heart being strong enough or not being strong enough. Make sense? So that's what's called afterload, because that's the load after the heart. It's the hypertension, the pressure coming back at you. Okay? It's kind of cool, isn't it? Yeah. What are the effects of autonomic activity on contractility? In other words, the squeeze of the heart. Well, sympathetic stimulation is going to cause norepinephrine to be released, and it's going to cause the epinephrine to be released by the adrenal gland, remember. That's going to cause the ventricles to contract with more force. So the actual contraction of the heart muscle is going to be stronger. If that happens, it's going to increase your ejection fraction. So instead of coming from here to there, you may go from here all the way down to here, because your muscle is stronger and it's pushing out more, and therefore increasing the ejection fraction, percent of blood that was in the heart that actually gets ejected with each heartbeat. I think the other factor to think about, I'm just going to mention this one right here, is called filling time. I said that when your heart beats faster and faster and faster, it still takes pretty much the same amount of time for your heart to squeeze, but now you don't have as much time for your heart to fill. And so even though your heart's beating faster, it may not be filling up enough to really improve your cardiac output. So that depends on filling time and rate of venous return. How well is the blood coming back? And I think I'll just leave that at that. What's cardiac reserve? Well, I had some patients in the past that were elderly, and I'm going to borrow this chair for a second if I can. And they would be sitting in a chair, and I would say, okay, Ms. Jones, would you walk across the room and back? And they would get up, and it was really a slow process. That was it. That was their maximum amount of exercise that they could do. Their heart was just on the edge because they didn't have any cardiac reserve. Now, on the other hand, you take put Lance Armstrong in that chair, and his heart rate's 36, and he's got an ejection fraction that's about 70%, and he's ejecting about 150 cc's stroke volume, and he can run his heart rate up from 36, which he is at rest, up to 210. And when he gets it to 210, he can keep it there for 2 hours straight. That's an incredibly strong heart. That's an incredibly amount of cardiac reserve. Now, when he's done racing for the day, he comes back, he lays down, his heart rate slows down, his cardiac output drops back to what would be normal for you and me. But he has this huge amount of cardiac reserve simply due to training, you know. Anybody know who that is? This is Albert Starr, S-T-A-R-R. And as I finish this talk about the heart, I got to talk a minute about Albert Starr. He lives just down the street here. Actually lives up on the West Hills up there. And he invented this little thing right here. This is called the Starr-Edwards valve. And it's the heart valve that he would put in both either in the aortic position or in the mitral position. He started putting them in a zillion years ago. Him and a guy who was an engineer by the name of Edwards, they developed this thing. And basically it's a metal ball that's nice and smooth so it doesn't form clots. And if you put it in the aorta, so the ventricle's down here below it, when the ventricle would contract, it pushes the ball up, and the blood goes out, and then snaps back. The ball closes, and it closes the valve off, gets ready for the next heartbeat. And these were inserted in the very early days of heart surgery, and the simple fact is they're still inserted. This is one tool that was 4 decades ahead of its time because it's still being used. And it's not used as much now because now they're using pig valves that don't require as much anticoagulation because blood clots do form on these things, so these people had to be kept on blood thinners all the time. I can remember I helped put in a few of those things when I was in cardiac surgery, in my surgery rotations, and I remember getting on the elevator with patients that had one of these in, and you could hear it across the room. Click, 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 click. I mean, it just was really distinctive and loud. That ball hitting the top and then coming back down with each of their heartbeats. You could really hear the Starr-Edwards valve. Here's the story on Albert. He became the medical director of Providence here at, what's this big hospital right up the street, St. Vincent's. He was really a world-renowned surgeon. He got his medical training in New York, and then he went to Johns Hopkins in Baltimore and did residencies in Bellevue, which is a New York City hospital, and Presbyterian hospital. Bellevue is where all the poor people went. Presbyterians where all the rich people went. He did a bunch of training there in New York City, and this was back in the 50s. In 1957, the University of Oregon Health Sciences Center out here wanted to start a heart program. They'd never done open heart surgery at all, and they said, if we're going to do it, we got to have an expert to get us started. And so they went and recruited him in 1957 to come out here to Portland and become the chief of the new department of cardiac surgery. Well, he put up with that bullshit for about 7 years of dealing with the university and